Okay, great. Let me just get adjusted here. Okay, so we'll talk a little bit about the ATTRACT trial, how it kind of developed. I'll tell you about the trial itself and what it found and kind of the medicine behind that. But really also talk to how in the world did it come to be? How did we get it started? What lessons can we learn about from that for the development of investigators, in IR? And I'm trying to advance, and I think what I did was hold on a sec here. I'm going to reshare. I think if I share the other one, maybe I can advance. Okay, let's see. Yes. Okay. A couple of the was done stents in the iliac vein were off-label. So here's how I look at this. I think that, objective wise, maybe after all this, we'll all have more comfort in kind of applying a scientific approach to venous care and, kind of realizing that, the development of the ATTRACT trial started, as so many things do, with making clinical observations, procedural observations, and then clinical observations, and ultimately grew into a rigorous NIH trial that was really focused on seeking a larger truth. I hope that you will learn to kind of expand your own scope. Again, there's so many ways you can distinguish yourselves in the field of interventional radiology, becoming a PI in research, but other things as well. But to do so, you're going to have to build kind of a collaborative ecosystem around yourself, right? And that comes from supporting other people and learning from other people. And the real principle behind these, and we pursue a rigorous approach, that's really something that will build your credibility and essentially be a great vehicle to expand your collaboration and impact. And then finally, hopefully you'll be able to embrace new pathways to elevate the station of IR and IR treatments. And I'll talk a little bit about the secondary effects of ATTRACT on the overall venous environment and the collaborative environment for interventional radiologists. So again, acute deep vein thrombosis really is the acute phase of a chronic disease, as we all know now. DVT, when it presents, causes severe leg pain and swelling. Typically, anticoagulation is effective in preventing thrombus from extending. It's effective in preventing pulmonary embolism. For those reasons, we shouldn't be talking down standard anticoagulant therapy. On the other hand, it's fair to recognize its limitations. Patients are diverse in their response to anticoagulation, and in particular, the effect of anticoagulation on the symptoms in the leg varies a lot from patient to patient. Usually, people do improve, but the time to clinical improvement varies tremendously from patient to patient. And fully 1/3 of patients don't return to their previous baseline quality of life at 4 months after treatment of their DVT. So pain and mobility reduction impair their quality of life both early and late, as has been shown in prospective studies. And again, a large part of that is you can see this middle image of a venogram with thrombus, the filling defect, really filling up the femoral vein here, causing congestion and then subsequent inflammation that results in those symptoms. Now, in the long run, that can ultimately evolve into something that we call post-thrombotic syndrome, which is, again, the more chronic phase in which patients develop chronic leg aching, swelling, skin changes. A minority of patients present with venous ulcers, such as what you see on the image on the left here. Now, it's very important, though, to realize that, we show these pictures because they provide a good pictorial representation. But then again, everyone doesn't get a venous ulcer. And really, when we go and characterize post-thrombotic syndrome to our colleagues, we shouldn't be implying that everybody's going to end up with a venous ulcer, for example. Overall, about 40% of patients who have a lower extremity DVT will develop some level of post-thrombotic syndrome, but it occurs on a spectrum. Some people have mild, calf or ankle swelling at the end of their workday. They elevate their leg in the evening, and it really doesn't really affect their life a whole lot. But other people develop much more significant pain and swelling that prevent them from moving. A minority of them will get skin changes on their leg, and then again, maybe around 5 or 10% will develop a venous ulcer. What has been shown, though, is that patients with post-thrombotic syndrome it tends to be a significant determinant quality of life of DVT survivors. Compression stockings have been evaluated for their ability to prevent this post-thrombotic syndrome, and the best evidence suggests that they're not effective in preventing the long-term issues. Now, they are very helpful in managing symptoms, in particular swelling, and when people have ulcers, they're very effective in managing the ulcers, but they don't prevent the development of post-thrombotic syndrome. And at present, there really isn't an effective therapy that prevents the condition. You know, a number of different medical therapies are currently being studied: direct-acting oral anticoagulants, statin drugs, other venoactive medications, but again, nothing is proven yet. Now, how does this develop? Post-thrombotic syndrome develops through a variety of mechanisms. And again, we don't fully understand it. We know part of the picture. What we have learned is that patients with PTS often have chronically occluded veins due to old residual thrombus and associated fibrosis. We know that many of them have both deep down the road that comes from damage from the inflammation due to the DVT. And then there are other factors that we just don't totally understand. And we have to understand also that patients that have swelling, well, there's lots of causes of leg swelling, right? And when people have congestive heart failure, or they have renal disease, or other conditions that promote swelling, that can interface with the effects of their DVT and contribute to post-thrombotic syndrome. Similarly, there are other causes of leg pain, whether it's arthritis, neurological conditions, whatever. And again, that can interface. And so post-thrombotic syndrome is a kind of complicated condition of which we understand something, you know. But certainly, if you take a look at the image on the right here, this is the patient who had a DVT, was treated with anticoagulation for a year, and a year later, you know, they were properly treated by standard care. But as you can see, this vein is completely abnormal. It's a septated, channeled, partly occluded, common femoral vein with lots of collaterals around it, results in venous hypertension in the limb, and that is the correlate of post-thrombotic syndrome. Now, catheter-directed thrombolysis, i.e., the delivery of a fibrinolytic drug directly into the thrombus using a multi-site hole catheter, has been performed since around 1991. There were actually studies, randomized trials of systemic thrombolysis for DVT that were performed in the 1970s and 80s, but this kind of took the form of catheter-directed delivery in the early 1990s. And what we learned during the early experiences are that, well, first of all, certainly if you put a thrombolytic drug into clot, it dissolves the clot as long as it's reasonably recently formed clot in the first couple of weeks. That's pretty clear. When that happens, many patients improved their symptoms early on. That was observed. However, fibrinolytic drugs cause major bleeding and rarely can cause intracranial bleeding, which use medical condition should be treated with a procedure that may involve additional risks of severe bleeding. That's where the need for data becomes much more important, right? But certainly it was a disruptive but very logical concept. What if, instead of waiting for people to develop post-thrombotic syndrome, we routinely take people with DVT and treat them with catheter-directed thrombolysis? Can we preserve their valvular function, prevent venous obstruction, prevent the post-thrombotic syndrome, and improve their quality of life? Very reasonable question to ask. And so we ultimately did this ATTRACT study. And I'm going to go back and talk about the kind of development of it later on. But I'll just start by telling you we ran this large multi-center randomized clinical trial, 56 sites across the United States, randomized 692 patients with acute proximal DVT. And again, just proximal DVT is popliteal above or above. In the case of this study, but they were randomized to receive or not receive pharmacomechanical catheter-directed thrombolysis. And all of them, though, received compression therapy and anticoagulation. So that's people in both treatment arms. And they were followed for 2 years with blinded assessment of their legs afterwards. And essentially what we found is that indeed, lysing the clot did remove venous thrombus. The veins did open up. We demonstrated that by venographic assessment. However, doing so did not result in a lower occurrence of the post-thrombotic syndrome over 2 years. It didn't It didn't reduce the occurrence of recurrent clotting episodes. There was an increase in major bleeding. Fortunately, no intracranial or fatal bleeding, but two of the patients had severe retroperitoneal bleeding that caused hypotension that required catheter embolization to save them. So there were a couple serious complications. And so overall, this was kind of a negative study on the primary outcome. However, that the severity of post-thrombotic syndrome was reduced in the people that got lysed. And in addition, their early symptoms, when they came in with leg pain and swelling, and we measured that in the first at 10 days and at 30 days via tape measuring their leg circumferences to look at swelling, and then also having them kind of grade their pain. And we did find that there were improvements also in early symptoms by using lytic therapy. We did a number of secondary analyses that we published in different journals. And ultimately, what we found is that patients whose DVT did not extend to the common femoral vein, in other words, fem-pop DVT, as we call it, smaller DVT, had absolutely no whiff of benefit anywhere in this study whatsoever. So really very clear they should not be lysed. The patients that seemed to have some benefit were those that had iliofemoral DVT, which is defined as DVT involving the iliac and or common femoral vein, with or without other veins. So common femoral vein or higher, you could say. Those are the ones that seem to have some benefit. We found that lytic therapy was less safe and less effective in patients over 65 years of age. So really the threshold to treat such patients should be pretty high. Again, no effect on recurrent clotting episodes. And we did not find a reduction in venous valvular reflux in patients examined with ultrasound at 1 year. And it was a pretty costly therapy. We actually measured it and did a formal health economic analysis and found that even for the iliofemoral DVT patients, $137,000 per quality adjusted life year, which is at the border of kind of intermediate value care, ranging closer though to low value care. 150,000 is the generally accepted cutoff there, So overall, not a particularly cost-effective treatment either. And we were able to create these beautiful graphs of quality of life. And so much I can take out of a graph like this, and I'll try and explain it to you briefly. But this is the change, the y-axis is the change in venous disease-specific quality of life as measured using a validated kind of questionnaire, okay, in the study. The middle two lines, the black and the green lines, are people who had fem-pop DVT, so the smaller DVTs, you could say. And as you can see, those two lines are completely superimposed upon each other for the full 2 years. So there was no additional benefit of lysing. Now, the top and bottom lines, the blue and red lines, are people with iliofemoral DVT, the larger clots. And what you can see as you followed them is that in the first 6 months, there was a pretty significant difference in the improvement in venous disease-specific quality of life that patients experienced. The people who got lysed did better. They kind of improved faster. Has been cut in half. And when you get to that 1 to 2 year mark, really, it's around 5 points on this particular scale, which is really near the minimally kind of clinically significant difference. So it's kind of a small benefit really out to 2 years, right? And as you can see here, between 6 and 12 months, the people that were not lysed, they kind of caught up actually, right? So you get a faster improvement and you get a little more improvement with lysis, but not nearly as much as we thought. So lesson number one for those of us in the interventional radiology field is if we follow people after a procedure, don't assume that what you see in a few weeks or a month or whatever it is what actually is going to occur to them down the road. We cannot look at short-term benefit and extrapolate that and assume that it means they're going to be that much better later, because we're not really giving full respect to the body's natural healing process. There are other implications. There's other ways to kind of look. When a lot of people saw the results at first, they were sort of disconcerted, right? And what they said to me, many of them, was that, Suresh, I want to believe this trial. I know you did it rigorously. I know you did it carefully, but it just doesn't jive with my clinical experience. I've treated these patients and I can see that they've improved. And indeed, what you can see from this graph is that if you just follow people that got lysed, right, they certainly did improve. In fact, we measured it. And if you take a look at the 2-year outcome here, the top blue line here, basically the patients that got lysed improved by about 27 points on this venous disease specific quality of life scale, which is a pretty substantial improvement over time, right? Here's the thing though, the people that didn't get lysed improved by 23 points, right? So really only about 20% of the improvement was due to the lysis, right? And then you have to weigh that against the risks and costs of undergoing that procedure, right? And so, people weren't wrong in what they were observing, but they didn't follow people long enough. And most importantly, they did not follow people that they don't lyse, right? That's a second lesson for us in interventional radiology, right? We have to be, if we really want to have insight into a disease, we need to know the full disease, right? And the effect of the other treatments, not just our own. And we need to understand the natural history of the disease when we don't treat it, right? We can't just look at the people that got treated and assume that what we did is what made the difference, right? And then the third thing I would say that is a very important implication is that right now, we have a lot of people, we now have sort of more modern thrombectomy devices, larger bore catheters that can kind of take out material that's older and more complex than just fresh clot, right? And so we have a lot of these people that get referred to us, and they're maybe, let's say, 1 to 3 months after symptomatic, and a lot of people are jumping in and thrombectomizing these patients, right? But again, I think we have to be very careful here, because if you take a look at this red line in the first between 1 and 6 months here, right, what you can see is that these people are still improving, right? We can't make the assumption that when we see somebody at 2 months and they still have symptoms, that we know that's where they're going to get to. In fact, more than half of the improvement occurs after 3 months, right? So that makes it hard, right? But certainly we have to be very careful. We cannot pronounce that somebody has failed their standard care based on just seeing that they're symptomatic or 1 month or 2 months or whatever, right? So again, you learn from these clinical trials, not just about the effect of a treatment, you learn the natural history of the disease. And that is the thing that I didn't know when I started this. I really didn't know until it was over and we did all this stuff that we're going to learn a lot more than just about the effect with this, actually, because we did some subsequent exploratory analyses, actually. And this was a paper that was written by Siddhant Thukral, who's currently a Duke IR resident. He was actually a student that did a TL1 research year with me a few years ago. But basically, we looked at a number of factors to try and predict, of all the information we had on patients when they presented in the ATTRACT trial, can we predict which patients will benefit from lytic therapy? And we looked at about 30 different factors, demographical factors, features of the index DVT, other comorbidities, and really not a lot came out. But what did come out very clearly is that the more symptomatic they were at presentation, the more likely they were to benefit, right? And they had, in other words, they had a larger difference in their Villalta scores at 24 months than the people who had lesser symptoms. And in fact, patients were characterized using this Villalta score at baseline. And baseline, if you look at the image to the right here, the confidence intervals for your 2-year Villalta score separate greatly, and are statistically significant, right? So that gives us a much more specific kind of guidance. So, we always hear, well, only treat them if they're symptomatic. But what does that really mean, right? People come in with mild swelling, severe swelling. Some can walk. Some can't even get out of bed without terrible pain. How do you really gauge that, right? Well, one way you can gauge that is by using a Villalta scale and applying it at baseline. And if it's above 10 and they've got an iliofemoral DVT and they don't have a high risk of bleeding, that may be the right kind of patient to treat. You're most likely to get a large benefit. And this is really what we wanted to do with a trial like this, is get very refined information on who should we treat and who shouldn't we treat. Overall, I think that this study provided strong guidance for DVT care. Lots of papers published, lots of different co-authors, which I'm very proud of, very significant collaboration. We won some awards. The different treatment guidelines that came out after the trial have all aligned themselves to the results of this particular trial. And it was really the dominant kind of piece of data that they relied upon to develop their guidelines. Now, they're not fully concordant because medical physicians and procedural physicians still do think a bit differently. But even in the medical guidelines, the American Society of Hematology, they didn't recommend using lytic therapy for everybody, but they have a paragraph that's written there noting that for some patients with iliofemoral DVT, it may be reasonable to do this. And we never had in the past any recognition that iliofemoral DVT is different than FemPop DVT. We've talked about it for a long time. The surgeons have talked about it for a long time, but it's never been recognized in the medical literature, you know. Only from doing this trial and the subgroup analyses were we able to achieve that, really, you know. And that's really nice to see that we kind of have a more refined consensus around this. And so now if you lyse your patient with iliofemoral DVT, you have some coverage, not just from the IR guidelines, but also from the hematology guidelines, right? Overall, we're able to help some of the iliofemoral patients. We can avoid harming the FemPop DVT patients, reduce the unjustified use of lytic therapy. Another benefit is that by using a specific TPA dosing protocol in the study, you now at least can calibrate safety events to a particular dosing scheme. And that can provide you some guidance as well. We never really had that before. And then I think the bigger impact was that through this project, and I'm going to talk more about that in a minute, there was so much collaboration that went into the development of the project among IRs, surgeons, hematologists, cardiologists, other medical physicians. And I think that really laid a foundation for a much stronger ability to collaborate around other aspects of venous care. So, for example, now, give all the credit for PERT teams to the ATTRACT project, but I do think that the ATTRACT project, you know, was one of the few major collaborative initiatives around that time that really laid the foundation to develop these types of new collaborations and enable us to advance care in other ways, you know. We also got some very interesting biological insights. As I said, we did some ultrasound follow-up in our patients, and we found some interesting things. As expected, lysing people resulted in less clot in the veins on ultrasounds done at 1 month and 1 year. So that was good to see. When the common femoral vein was open at 1 month, those patients were less likely to develop post-thrombotic syndrome, and they had better quality of life at 2 years. That was kind of encouraging and supportive of this kind of open vein hypothesis. But on the other hand, what we found is that even at 1 month, a substantial proportion of the treated veins, the ones that we lysed, even the ones that were open, they had clot in them, you know. And in addition, we didn't reduce valvular reflux. And so even with excellent lysis up front, a lot of the veins essentially redeposited thrombus. And that's very important again, because we've never really measured, or we don't have a good way to measure, what's the effect of messing around with catheters in there, right? And one of the effects probably is that depending on how aggressive you are, the body is going to respond, right? And it is going to redeposit, you know, thrombus to some extent. And that may be what undermined the results of the study in terms of giving you the large, compelling, positive primary outcome, you know. And I think it's very important and relevant for current practice because now clinical practice has evolved towards avoidance of thrombolytic drugs and use of large bore mechanical thrombectomy devices. But again, you got to ask yourself if using the techniques we did, where we pre-lyse the inflow veins, we use a medium-sized catheter, we use an 8 to 10 thrombosis, what's it going to be like if you take a 16 French sheath and stick it in the popliteal vein and you scrape the wall of the vein and you don't lyse the inflow veins? Is it really going to be better in terms of preventing PTS? I'm pretty skeptical about that based on what I've learned, but we're going to have to see through clinical trials of mechanical thrombectomy. So now I'll turn my story a little bit to the part that the stuff I didn't tell you, right? And really the question is, you know, I have an MD just like most of you. I don't have a PhD, no master's degree in any type of kind of scientific area. So how did an IR basically, without any formal research training, gain a multi-million-dollar, it was a $10 million NIH grant, and the trust of medical thrombosis leaders to lead a big pivotal trial like this without really having a lot of experience before that and no NIH track record, you know? Is there some type of IR-friendly NIH funding pathway? Of our limitations sometimes, but we forget that we actually have some things to offer that are pretty special compared to other fields. And then we have to ask, the way I hear people talk about the trial, and it's obviously gratifying to hear people say nice things, but sometimes there's a sense people convey of thinking that this is somehow an exceptional one-off, right? But I think the reason you've put together this series is that you all know, just like I do, of course it's not a one-off, right? Of course such things can be done again, right? But hopefully we can learn from what we did in the ATTRACT trial and other areas to try and guide people in trying to do that and do other things in the future. When you think about, what I was trained to do, basically just like you all, I was excited about doing cool procedures. That's how I started, as you can imagine, right? And my clinical sensibilities really just like most people evolved from clinical observation, not necessarily from data or evidence. But then again, there were some benefits I had venous cases when I early in my career. So, we forget the fact that, well, even now, as a sort of, kind of leading expert in this particular field, how many thrombolysis cases have I done in my life? It's probably on the order of hundreds. But when you think about other types of cases, I've put in thousands of venous access lines of every type. I've done thousands of dialysis, hemodialysis, graft-related procedures. I've done TIPSs. I've done filters. I've done literally thousands of venous procedures and thousands of recanalizations that had nothing to do with lower extremity post-thrombotic syndrome. And in doing so, there's an incredible amount of clinical experience you gain. No other provider interacts with the human body like an interventional radiologist. You just perceive things differently because you have a combination training that involves imaging and clinical care and imaging guided interventions. And that's a very unique advantage because when I go to meetings, I'll hear people showcases or talk about what they've seen or make observations. And there are times when I know I can just look at that and say, no, that's not really the right conclusion you're drawing there. There's a kind of can't fool me just from the clinical experience and having dealt with the venous system in so many different ways. And you're going to gain that as well. And that applies not just obviously to venous disease, but the fact that you do different kinds of arterial procedures, different types of non-vascular procedures, you use different types of imaging to look at the same thing, right? So there's a really unique advantage here that does play to our benefit in certain ways in being able to understand things that others can't, right? I was lucky in that I got exposed to DVT treatment with some of the pioneers in thrombolytic therapy, both arterial and venous thrombolytic therapy. And how did I start with this? Well, when I was a fellow, I was asked to write a review article on DVT, and so I did. And by doing so, I did a literature review, and I did it seriously. I took the scholarship side of it very seriously, and I learned a lot about it. But at no point early on did I think, oh, I want to go in and study venous disease. It really wasn't necessarily the thing I was thinking about at the time. But early in my career, a few years in, I did a case that was, something like this one here. We had a patient who had acute thrombosis of an IVC filter that you see here. If you look at the upper right image there, the cava is occluded. You could barely make out an occluded trapeze filter there. But as you could see here, you've got the left and right iliac veins completely full of acute and subacute thrombus. We performed catheter-directed thrombolysis, angioplasty, and then stented the veins, and we got a result like this. And that patient dramatically improved. And this is the thing that the light bulb goes off, right? When you do these things in interventional radiology, and you ask yourself, geez, why aren't we treating all? In my great wisdom, I thought, let's do a study and figure out the best way to do this procedure, right? And so I actually approached one of our pulmonologists and said, hey, why don't we do a study where we compare catheter-directed thrombolysis versus pharmacomechanical catheter-directed thrombolysis, where we add a device, right? And see which one works better. Expecting, hey, great, someone's proposing a research collaboration. What did I find? It was a bit of a train wreck, because there were a couple of problems. First of all, he was utterly outraged that I would propose a randomized comparison of two procedures that in his view were both unproven relative to standard care, right? The standard of care of DVT is anticoagulation. He's wondering what in the world are you doing in the first place, let alone trying to compare two different things. The second thing I got out of that conversation that was that he may not have meant to convey an IR leading a clinical trial in a disease like this as a thing at all, you know? And so I was pretty discouraged, you know, at that moment, actually. And then similarly, when you look at the 2004 chest guidelines, this is the kind of master anticoagulation treatment guidelines that the American College of Chest Physicians produces. Essentially, they dismissed the use of this form of therapy entirely. Pretty much said that it should be limited to patients who have phlegmasia cerulea, meaning their leg is acutely threatened, you know, with their DVT, you know. So I had these unpleasant realities, you know. First of all, I realized then that, okay, we're going to actually need to prove benefit before anyone's going to start to adopt this as a routine thing. And then secondly, I realized that in trying to have a conversation with someone like that, I have more homework to do. I need to learn more to be able to have the conversation in the first place, right? And so that got me, you know, on a pathway of what I would call scholarship. And I think that, you know, this is something that we don't talk about enough, you know, but I think that, you know, there are people that if they get asked to write a review article, will go and find 5 papers and write the review article. And then there are people that when they write the review article will find 50 papers and write the review article. And then there's the rare person who has gotten 100 articles and is paranoid that he has missed 1 or 2 that his faculty mentor is going to pick up on. That was me, you know. So, you know, I think that, but I would say though that extra work that I did that really wasn't asked for played a huge role in learning the language because I read papers that weren't just IR papers, but they were medical therapy papers, right? And I learned the language a little bit of how a medical physician talks about DVT, right? And that's going to be very, very important, right? I was also asked in 2003 to lead on behalf, I had written a few retrospective papers, you know, just 10, 20 case wonders, as I might call them now, looking back at them, and that I published in JVIR that were written just on our clinical experience locally in doing DVT cases, really. They were nothing special, believe me. But, you know, they're a good exercise. You know, I think that it's important early in your career when you start doing things, you know, get in the habit of trying to public, you know, to submit abstracts to SIR or other places, write papers, because you will start to, you're going to get feedback then on your work, right? And then you're going to understand how other people look at the work and how they judge its veracity and its credibility and all that. And that's what's going to elevate you really and make you kind of challenge you to improve yourself, right? And that's essentially what happened to me is I got blown out of the water in a conversation by this guy. And then you start to present, you know, you write improve your game, you know? So I was asked by SIR to lead a DVT research committee in 2003. And again, the irony being, of course, at the time, there really wasn't organized, any organized DVT research going on really at the time, right? But by doing so, I approached the SIR Foundation for help. I learned pretty quickly that we're going to need to do a randomized trial, but how in the world we're going to do that, I had no idea really. And we decided that we would start what's called a research consensus panel that the foundation puts on, whereby they invite an investigator from IR to bring in other leaders from other fields and have a serious discussion on research priorities. And that gave me a platform, right, to go ahead and reach out to the names I had seen on these papers that I had reviewed, right, and bring them in because I could identify who were the bigger names, you know, bring them into a process with SIR. And in doing so, what I thought was that, okay, well, we're going to qualify to run it, and they're going to go ahead and run some trial. And that was going to be my impact, was in putting together and being the catalyst in this process. What ended up happening was that by virtue of being the person out there putting in the energy and kind of being the prime mover, the other leaders outside IR began to see me as the prime mover. And I didn't anticipate that up front. I really didn't go into it saying, I'm going to lead a randomized trial. It was, I'm operating on behalf of SIR, and I know we need a randomized trial, so I need to figure out a way to engineer it, So some of the things that I learned about this are that, when you think about who's the ideal NIH PI, yeah, you'd want a senior faculty member at a top-notch academic institution, NIH track record. They've done multi-center trials. They're a disease expert. They've been trained in trial methodology. None of which really apply. Acceptable is, a mid-career investigator who becomes an expert either in the disease or in some intervention, right? And we have to remember that IR procedures to the NIH, you can be doing something for 15 years, okay, in an IR practice. At NIH, they've never heard of it, okay? The stuff that we do sounds really innovative. It is innovative, but it's innovative for years after we consider it innovative to the rest of the world, actually, right? So that's an advantage that IRs have when it comes to proposing things to be funded by federal agencies, et cetera, right? As I said, just by being energetic and determined, I began to be seen as a prime mover. And then I was able to recruit mentors, right? And the key thing with NIH in particular is that they weren't putting their bet on some junior guy. They were putting their bet on the people I surrounded myself with, who were experienced trialists, experienced NIH benefit in IR from this type of model too, because, I think, a cardiologist, their patients, come right to them, right? I mean, if you're a cardiologist, really, everybody with an MI gets sent your way, right? So if you want to do a trial on acute MI, the patients are there, right? For IR, right? Patients don't just necessarily find us, right? We're usually not the primary care provider. People have to refer them, or the patients have to know to find us, right? That gives us a natural collaborative mentality. It's part of who we are. That puts us in a great position to build the teams you need, whether it's to lead a PERT team locally, whether it's to lead a small clinical trial, whether it's to propose an NIH grant, right? We've got that collaborative mentality. It's actually a strength, not a weakness, right? So I went ahead and recruited mentors, and in doing so, I was able, because I had read a lot of articles, to kind of try and speak their language. And that helped me overcome the kind of pro procedure. And we have to learn to talk in a much more neutral way about what we're doing. I wasn't there trying to prove that thrombolysis works. I'm trying to determine if it works. And we have to be able to talk that way, right? I also was able to interact with them and learn a lot about the clinical environment around DVT, stuff that I wouldn't learn from just practicing IR, right? And understand their scientific perspectives and their concerns, right? Much of which were centered around the fact that, look, Suresh, I can treat DVT patients, thousands of patients every year, put them on anticoagulation, and I'll never see an intracranial bleed. You're trying to tell me that we need to be lysing all these people. You understand what that really means if you start to do that on a large scale? You're going to start to see these terrible things happen once in a while, right? You better know that there's a benefit, right? So I learned a lot about that, right? And the mentors were amazing. Some of these people were just amazing people. And you see on the left, Tony Camarota is going to do this. Us vascular surgeons should stand up and submit a competing trial to the NIH. And Tony stood up, this is before the trial, and said, hey, wait a second. This kid is actually making progress. We should get behind this process, okay? That was a really heroic thing kind of to say, really. He went against his own specialty's interest, right? I had David Hunter, who is an IR from Minnesota on the bottom left, who basically gave me just the simple help of coming up to me when he saw that I was a little bit wavering at a meeting and saying, you're a force. I had Tim Murphy, who had actually served as a co-PI on an NIH trial, teaching me about the NIH process and reminding me that if you're submitting somebody to the NIH, if the person that you're collaborating with is not the best in the world, it's going to get reviewed as a weakness. Well, that was an interesting lesson, right? And then Sam Goldhaber in the upper right, one of my great friends and mentors, he's a cardiologist at Brigham and Women's and a kind of a I provided him my analysis of how we're going to enroll people in the trial, right? I had this big scientific analysis to figure out which trial sites are going to do well, what's their patient volume, what's this, what's that. He said, Suresh, that's really terrific. And that's a great analysis. But do me a favor, go out and find your 10 best friends and make sure they're on the trial. He was a very pragmatic person, and it's so true what he said, right? It was those personal relationships. Those are the people that ended up being my best enrollers in the trial, actually. And all the analysis I did really didn't amount to that much, really. I also learned that there's such a thing as professional expertise in research, believe it or not. We're trained to be great doctors, but remember, being a great scientist is a different thing, and being an effective trialist is even something else that very few people get trained in, right? Doing clinical trials and getting that training. Two mentors here, Susan Kahn and Clive Kieran, incredible trial methodologists. Without them, there's no way I could have proposed a trial to the NIH that could have gotten funded, right? So interacting with your local biostatisticians and finding mentors to help guide you in trial development is important. And they taught me so much about trial methodology, measurement, minimization of bias, and we were able to design a trial that incorporated a lot of these important aspects, really, because you're trying to do something very complicated, because the venous thromboembolism community knows what trials look like in their world, right? And they expect to see your trial looking like that. On the other hand, when you're doing procedures, right, you have to be able to evaluate procedures properly. And that involves some different things that you have to introduce in and blend into that trial. So again, that collaboration is very important, right? Now, in doing so, by demonstrating that interest in collaborating, that I got invited to so many work groups, panels, for so many different organizations. People think that all these accomplishments came after I got funded and after I delivered a completed trial, but that's not true. It came when I was putting in the energy and convincing people that I wanted to be rigorous and report results honestly, et cetera, et cetera. That is what built the trust. And I really hope you take that lesson to heart. It's when you showed the rigor, you wouldn't believe how many people are just waiting for a young IR to come along, right, in their particular disease area. And once they find someone they can trust, they will support and they will invite you into things. And I was honored to kind of, I was invited to the Surgeon General's workshop on DVT in 2006. That was obviously a pivotal moment. And then I was invited to lead a large coalition of organizations, just because of the energy I was putting, which was just kind of an amazing thing, back in that time. A lot of things were happening to try and kind of mobilize around DVT prevention. And by showing that I was willing to put my time into DVT prevention, I think that I established my bona fides as somebody that wasn't just caring about pushing procedures, but someone that cared about helping people with the condition, right? And so that's how my career kind of developed. It was that energy that led me to all kinds of crazy places, and led to a sense of credibility probably around what I was doing. And we actually were able to get the Surgeon General's office's active support for the ATTRACT study. And I met 3 consecutive Surgeon Generals in that time, actually, to get the government's kind of blessing behind what we were trying to do. Obviously, our timing proved to be very optimal. A lot of good coincidence in our favor, but we put in the energy and showed the rigor to get collaborators on our side. So I think that the lessons I take are that for IRs, you can use a non-traditional pathway. People think that you need to you need to do a small pilot grant and then a larger grant and this and that. That can take you 20 years. What I find is that if you become a clinical disease expert and publish a few times and then start to collaborate and get partners, I think you can leverage the kind of the excitement around imaging guided procedures to really deliver something that is very unique and gain support for what you want to do. The NIH outreaches into the community, and they want to identify people who are going to be the investigators. They want to identify what's new out there that can advance health, right? And this is your opportunity to interact with them. find mentors both in and outside our field, and ultimately be rigorous, and that will elevate the field. And eventually, that led into my second career. In 2008, I became an investigator. Again, I was inexperienced to the task. I had to build an internal clinical coordinating center. We ended up activating 70 sites in this trial, involving lots of personnel. Had to learn how to manage a large budget. Obviously, there were all kinds of subawards, for the contracting with sites for the work that had to be done in the study. So I got kind of a trial implementation crash course, really, and learned an awful lot in that process. And you have to know your study's value proposition, make it as clinically friendly as possible so it's non-burdensome to really get it done, and ultimately focus on meeting your obligation to participants, right? You want the patients to think helping the study is easy to do. You want their providers thinking this study is good for my patients, right? And that involves a lot of interactions with your research staff, learning from them as well. We were able to parlay that into a second trial, the C-Track trial, using a lot of the same large randomized trial focused on venous stenting for chronic venous disease and iliac vein obstruction. We have enrolled 223 patients. That trial is going to finish this year, and we'll have results next year. And then the greatest honor really was in mentoring Dr. Sista from who was at what was recently at Cornell University, and a PE disease expert. And this is an interventional radiologist who really built his career in a similar way, becoming a disease expert, very credible outside our field, showing the energy to lead a trial. And he ultimately got funded for a large NIH-funded multi-center trial evaluating catheter-directed therapy for submassive pulmonary embolism. And this is a study that is currently ongoing, actually at 52 US sites, and it's focused on long-term outcomes in pulmonary embolism. And he's just done some amazing work in really being a trailblazer in this particular area. And, that led to further things for me, in the sense that by running an investigator-initiated trial of this complexity, my institution kind of realized that maybe I could help other investigators. And, I've taken on another role in trying to help our institution really not just be a research administration, that's kind of a hurdle, but really to provide expertise in the center of our university to help investigators develop their studies. And I now run a unit called Trial Care that's focused on helping investigators from all over the university, not just interventional radiologists, develop their studies really and get funded for them, and ultimately be done efficiently. We provide consultations and guidance. We provide staff support to actually run the trials as well. So this is kind of my other career now past interventional radiology. So my conclusion really is to just be devoted to finding and following the truth. There are some great examples of how, I think acute stroke is the best example. Came up negative for endovascular stroke care, and everybody was mourning it and all this. But then subsequently, we learned from that trial which are the patients that should be treated maybe, where's the real opportunity, let's innovate with devices that make them better. And then there were subsequently 3 major studies that were positive for acute stroke care. And that's now considered the standard of care in patients that have acute stroke. So, again, just following the truth is going to bring you collaborators. And if you prioritize scholarship and collaboration and engagement, you're going to be able to lead as we did here. So I will stop here and see if there are questions. I hope this is the sort of thing that you were interested in.
Thank you so much, Dr. Vedantham. That was amazing. That was like everything I wanted and more. Yeah, so now just some time for Q&A. I've got lots of questions, but gonna open.
Thank you, Dr. Vedantham. Thank you for pioneering for us this new path of doing research as an IR. I was wondering, did you seek mentorship from other areas as well? You mentioned that this is initially a huge collaborative effort. Did you find valuable mentorship maybe in surgery and hematology and things like that?
Yeah, absolutely, and that's really important. I mean, I think the first place to go is within IR when you can. Now, obviously in IR, you can get great clinical mentors. That's pretty easy, right? Finding research mentors is, it's getting easier. I mean, I think it was pretty challenging to find people that could, lead you through an NIH process, certainly, but I think it's more possible now. But again, getting outside our field is very important for learning the disease and learning how to talk the language of an investigator. You have to sometimes to get kind of to learn the lessons needed to be able to talk in a more rigorous way. But once you start doing it, I do think that you're going to be able to, I think that our field's very attractive, and what we do is so unique and innovative that I think that once you're able to talk the language, I think that finding people who want to mentor an IR, I didn't find that proved to be not the hardest thing, actually. I don't know.
Naveed, if you want to go ahead and ask a question.
Yeah, thanks again, Dr. Vedantham. I had a quick question. I guess maybe a little bit multi-parted, but you can feel free to answer all in one fell swoop. But if you're, I think depending on which side of, if you're on the research side or the physician side, we're talking about level one, evidence, clinical trial data that, inevitably will. An example where when the results of the ATTRACT trial kind of came out, there was kind of this disparity where physicians that you were speaking to, they were like, oh, this isn't what I'm actually seeing in my practice, right? And so, my question to you is, when we get this, high level data that's obviously randomly controlled, it's the best that we can do in terms of doing evidence-based medicine. When you have these disparities on the physician side, how do you rectify that? I know you kind of mentioned like following a lot of those patients that you, for example, for DVTs, just the pharmacomanagement essentially versus intervention. But, I kind of am curious because, for example, those physicians, they might not see the patients who are just, purely treated unless they were, consulted for possible catheter-directed therapy. So then I'm just curious, in your opinion, how would that work? And then if you're on the research side as well, how do you rectify that too?
I'm not going to give you an easy answer, but I think that, starting early, realistically, what you're in training, and right now it's obviously you're at such an exciting point in your career development, right? You're going to go and you're going to enter the real world with a job at some point soon, right? And then you're going to have to adapt to that practice, and that creates a lot of challenges, right? Both in terms of just enjoying what you're doing and all this, but then also time wise, right? There's more and less sympathy for different kinds of activities, right? And if you want to see a bunch of patients with DVT that are not even going to be intervened on, that's not an easy thing for most practices to manage, right? But I still think we need to do it to some level. I mean, we may not need to see every DVT. I know I'm not saying we need to see every calf DVT that comes in, but if you just take a look at like what's happening in pulmonary embolism, right? We're on the phone who probably don't need to be treated, and those that do with endovascular therapies. And the experience of hearing about all the patients, right, and evaluating all of them is very informative in our ability to make the decisions, right? So I just think that we still need to work to, and this goes beyond DVT, but in other areas, find a way to get exposed to the population, even the ones that we don't treat. A joint hematology clinic, okay, to see people, right, in the long term, right, that have this condition. And by doing that, if we'd done that simple thing years ago, we would have figured out, geez, you know what? I'm surprised, but even some of these iliofemoral DVT patients actually look pretty good down the road. And even, we would have known that, right? And we didn't know that up front. And so we made a very bold hypothesis, and the primary hypothesis didn't pan out, right? I think it's just so important to do that. But I think going beyond that, it's also how we teach each other to communicate, right? We routinely look at single arm point A and time point B, and there's clinical change, and there was a procedure somewhere in between, and we allow ourselves to say the procedure caused the change. That's wrong. It's not the same, that you can't attribute unless you have some kind of control group, right? I think that we can start early on with, in our training programs and overall, just in the way that we communicate, always reminding ourselves that we really shouldn't do that, because we're setting ourselves an expectation there. And then it becomes very hard to do the trial, right? Because now everybody believes that it works. How do you randomize a patient to not get the intervention? That's the hardest problem we face when we do these trials, right? And it's ridiculous in a sense, right? You're saying that you want to take a patient with a disease that's been treated medically for 50 years and put them through a procedure involving TPA that could give them a brain bleed, right? And you're saying, how is it reasonable to not? But so we have to work. We just have to, right? And it's not going to be easy. Everybody won't be convinced. I'm not saying that will be the case, but I think that will set the ground such that in the future, when a trial result comes out, there will be a little bit more, that phase of grief, that 5 phases of grieving don't have to take 5 years. They could take 3 months, and we can start to think about the results in a serious way soon thereafter, right? I think we can do better with that.
I think we have time for one more question. Shakti, I see your hands up.
If there are more questions, I can't see the thing, but if there are more, I can stay longer. So don't feel too, yeah.
Oh, thank you, Dr. Vedantham. Yes, I was just curious. In that track trial, there was earlier assessments at 1 month and 3 months, but there was no scoring of the Villalta at 3 months. Do you think scoring at 3 months and beyond 24 months could have given better understanding of the PCDT?
Well, we scored Villaltas actually at 10 days, 30 days, 6 months, 12 months, 18 months, 24 months, which is kind of a lot, really, if you think about it from a patient perspective, Now, so I don't think 3 months would have made any difference, but when it comes to beyond 24 months, if it were practical, yes. I mean, I think that, because I do think that, even 2 years, is a limited time frame. But when you start to think about the realities of clinical trials, one of the other challenges we have, because we're not in the habit of following people without intervention, when we did the ATTRACT trial, one of the main, if you say methodologically, what was the main downside? Besides the fact that patients know if they got lysed, the other main downside was that the follow-up wasn't perfectly equal. In other words, didn't get lysed. And that creates several problems from a trial evaluation perspective. But I think also, it would have made it more possible to extend and go to 5 years if we had done better through 2 years, because, we thought about that. Should we try and extend? The problem is that the patients were distributed across 56 sites, right? So to extend, you got to get 56 IRB approvals. You need money and time and bandwidth to do this, right? You got to kind of locate the patients. By the time the trial enrolled slowly and everybody was exhausted by the time we got to the end, so trying to get people to go any longer would have been very difficult, and so it was going to be a tough thing to do. But do I think it would be valuable? Yeah, I do.
Thank you. And just a quick follow-up. There's more studies like the cloud registry just with no randomization. Do you think like the 2-year results of the cloud registry adds more understanding to the PCDT?
So the cloud registry is focused on, again, mechanical thrombectomy, right? I think that you get certain kinds of information out of single-arm studies and registries, but then if you want to talk about the effect of a treatment, you need a control group. You simply can't do it without a comparator, right? Because if you think about it, the cloud registry documented outcomes out to a year, and then even 2 years, I think, but you don't really know what caused those outcomes. It could just be anticoagulation, right? It could have nothing to do with the thrombectomy device, right? I mean, you have no way to say it because of the thrombectomy device, right? So I think that's the problem, right? And the other thing about cloud was that they did not have independent outcome assessments. In other words, the assessments of Villalta score and all that were done often by the physicians who did the procedure. They were not blinded to whether the patient got treated, right? So there's bias there, right? There's a strong than what they were in the ATTRACT trials control group, let's say. A lot of it probably is just simply because of who did the assessments. It's people that weren't blinded to treatment, right? And then similarly, the ultrasounds were not assessed by blinded sonographers. There wasn't a core lab, right? So I think it's worthwhile to do the study. You do gain some kinds of information on who's being treated out in the community. What are the safety issues with the device, for example? You can kind of characterize safety when you use the device a lot. But in terms of determining efficacy, you cannot do it via a single arm study because you don't know what's the effect of time and natural healing, what's the effect of anticoagulation, compression, other treatments they may have gotten, right? It's all mixed in, right? So you need to do those randomized trials. Now, there is a trial called the Defiance study that is a randomized trial that Inari is sponsoring, looking at the ClotTriever device. That is ongoing. The challenge, though, is that the way that they have set up their primary outcome assessment is that, unfortunately, it also is kind of prone to bias. It's an industry-sponsored study, and so often they set them up to have a particular result, obviously. And that one, unfortunately, they had the opportunity to set things up in a blinded way, and they chose not to. They were encouraged to do so many, many, many times and didn't. And so the other lesson you should take away from that is that the ultimate veto on something like that isn't the person with the purse strings. It's the person who has access to the patient. So I think that, if the investigators put their feet down and collectively got together and said, we don't think this is a good way to do things, we're going to together go to the company and say, no, you got to change this. Otherwise, we're not going to enroll people in the study. The trial would be designed properly, right? So I think that we should take responsibility for trying to make money. That's what companies do. But the point is to take our share of the responsibility, right? And make sure that the trials get designed properly.
Okay, thank you so much. Thank you.
Sure.
We are aware that it is now 3:05 Pacific Standard Time. So for anyone that needs to leave, please feel free to leave. But if Dr. Vedantham has a few more minutes, I think we have a handful more questions from people. Sure. Okay, Naveed,
absolutely.
Go ahead and ask your question.
Yeah.
Thanks again. Sorry, really quickly, I just wanted to ask, kind of your path to especially getting involved with randomized clinical trials. You kind of cited that it didn't really just start out that way. You kind of started out as like becoming an expert and really, building, a core group of people that you could trust to help, drive these, research goals, points where there isn't really as much clinical trial level data available for whatever disease pathology that you're studying. My question to you then is, how do you kind of parse through the data that is already pre-existent? So, kind of the lower quality of evidence, but, what is your, I guess, in your experience, what has been the way that you kind of parse through that data? What do you trust? What don't you trust? Because not all research is really created the same. So just curious if you had an opinion on that.
Yeah, no, it is challenging. I think that I think it's important to when you read articles, obviously, you really have to you have to get in the habit of kind of critiquing them a little bit, right? And not from the perspective. I mean, I think that sometimes things get we sit in a journal club and somebody puts up an article and we beat it to death. The purpose of it is to ask yourself, what can you draw from here, and what do you have to be careful of, right? So we don't want to dismiss people's efforts to write up whatever they've done or whatever it is. I don't think that's the goal, because I think you gain, the retrospective papers you write, the single arm studies, they all add a certain bulk of observation there. But I just think you have to be a little bit careful in how you go, in drawing full conclusions from that. But so when I look at studies, I'm looking, is it retrospective or prospective? To what extent did they say what they were going to do beforehand and then adhere to it? Where could they have biased things? Did they independently assess the outcomes? That in our field, I would say, is the number one thing for me. Is this, did the doctors just assess their own treatment? Because none of us are are fully unbiased when we assess our own work, right? I mean, or were there independent assessments and how did they stick to them, you know? And independently assessed studies, even if they're retrospective, like if you say to me, okay, well, we did 50 cases of X procedure and we evaluated the venograms, and the people that evaluated the venograms didn't know if it was pre or post treatment, and they didn't know which provider did it, and they can't tell from the images that there are devices on there to know the devices have already been used or whatever it is, and they came up with certain findings. That means a lot more to me than something else might, right? So I think that you want to look at the research design there, and then you're always weighing it against your clinical experience at the end of the day, right? And trying to understand what could they have missed as well, and sometimes you just have to be the one to push ahead, and it doesn't always have to be a big NIH randomized trial, right? Asking a simple, small question, but doing it in a way that enables you to at least get the answer in the least biased way, that is very worthwhile. I think, it's so easy to look at the big study or whatever, get some experience in writing up retrospective stuff, but then also think of a small question you can ask, right? And design it in a prospective way. But just do something small well. And I think that is a really great experience, actually, Did Joji, did you want to add a comment?
Yeah, no, I had a question since you were bringing up some of these kind of industry-sponsored trials. And first of all, thanks for doing this. I think really encourage the next Vedanthams and Sistas and Murphys of the VIR community to kind of emulate what you've done. But as far as the win ratio is a primary endpoint where they use kind of composite of multiple things and having different weighting. What are your thoughts on that as far as bias?
Well, so it's people have struggled with the notion of, okay, to take the obvious example of pulmonary embolism, for example, can every study look at mortality? And secondly, does it occur frequently enough to do a feasible statistical comparison of it, right? And at the end of the day, that's always made it very hard to do research in pulmonary embolism, So there are different kinds of strategies people have used. A true composite outcome, which is different than the win ratio we're talking about, is a way that you might say, okay, well, let's take death and clinical deterioration and recurrent pulmonary embolism and just count those events and report that. The problem with that, obviously, is that some events are more important than others, right? You can't compare death with almost anything else really that easily, right? And so people do propose composite outcomes and they get beaten to death by reviewers typically, but sometimes they will push ahead and do those kinds of trials. Now, win ratio is a really excellent and creative way to address this type of problem. And just for everyone here, just to simplify it, a hierarchical win ratio enables the most severe or important outcome like death. And if there's a difference there, if a patient died, we're going to count that as the death, and then that's the end of that comparison. But if neither patient died, we're going to go to the next step outcome, which is the next most important outcome, and then go down from there, right? The challenge comes when you start to combine maybe like there are obviously patient care and safety and efficacy outcomes. And then there are other kinds of outcomes, like, for example, in the Peerless, pulmonary embolism trial, they bundled in ICU time, in there, for example, and they ended up declaring a positive result in the study in favor of thrombectomy over catheter-directed thrombolysis. And based on a difference really in that outcome, I think that goes to the spin. The company may put their spin on things, but bundling in, something that really wasn't a patient clinical outcome. But I do think that, length of stay, I do think that it is a creative way, and it provides a way to get these studies done in a reasonable way. Because at the end of the day, we got to remember too, from our perspective as IRs, the acute MI trials had 40,000 patients, okay? We're not going to be able to do trials with 40,000 patients, right? I mean, it's just not feasible because we're studying the interventions against medical therapy, right? That makes it very difficult and expensive to do it, right? and the diseases aren't as common as coronary artery disease, which goes right to the cardiologist, right? It's much harder to do it. So we need some way to do this in a sensible way. I think in the ATTRACT trial, we had a reason why we chose a binary outcome for the primary, but it had its downsides too, right? Because at the end of the day, lysing people did produce a difference in the natural history of the disease, right? But that wasn't reflected in the primary outcome we chose. And so, finding ways to do trials and ask questions, that can show you the difference when it's there in a reasonable way, I think it is valuable. And I like the idea of the win ratio. It just, it comes down to how it's done. Other questions?
I have a question for you, Dr. Vedantham. So as students, we are often exposed to literature. We read PubMed, go through the landmark trials, etc. But there are certain interventions that we do that don't have a landmark trial. For example, GAE, right? Like there's no big trial that's done on knee OA other than like, I guess, Padia's work, and some longitudinal stuff. Like what do we make of the retrospective trials that exist? Like how do you use that to counsel patients we should or should not do something? And or what should we as students do with areas that simply do not have enough research for us to be like, okay, we are actually doing the right thing for our patients?
Yeah. Well, first thing to realize is that every intervention may not be suitable for a randomized trial. That's the first thing. It's a hard thing to accept. I mean, I think, but I think that realistically, there are some kinds of interventions where it's going to be very difficult. Some populations are just too sick, to have a randomized trial. Sometimes for different reasons, it's hard to get them to want to randomize. But many things more things than we think can be studied that way. And sometimes you're basing things on your clinical experience and retrospective studies. I think the key thing is what's the comparator, what's the existing standard of care treatment? And the example I'll give you is that endovenous ablation for saphenous vein reflux, right? The standard of care procedure that had been around for years and years was surgical stripping of the vein, right? So when endovenous ablation came along, we didn't really need. Why? Because what we're offering is at such a lower risk and better convenience and reasonable safety, that the imperative of getting the randomized trial, okay, it's a little bit different, right? I mean, in that case, you're going from a surgical therapy to a less invasive, more convenient, safer therapy, right? In that case, I think that when you rely on retrospective data, it's not perfect still, but at least you can say that from the patient's perspective, right, we're not subjecting them to risk, right, without justification. When you go to taking a patient with the place, and if you think about the way IR has advanced care for whatever it is, 50 years, a lot of it has been going from surgical to less invasive, right? And so we didn't necessarily need the randomized data in order to convince our colleagues that we've always bumped our heads is when we try and go from a medically treated disease to something that that we're saying needs an invasive procedure. And there are some hazards here because to do it, we've done some very interesting things. We have actually concocted biological justifications for doing so. And if you think about what happened with CCSVI maybe 15 years ago, chronic cerebrospinal venous insufficiency, right? And this idea that we could go ahead and balloon up jugular vein stenoses to treat multiple sclerosis, okay, and get improvement there, right? All the warning signs were there from the get-go, okay? And the neurologists know once a year, a new therapy comes along that somebody says works for MS, okay? And it's studied in single-arm studies, and it's almost always a placebo effect that's, right? So when that came along, this was a place where, again, we fell apart, right? Kind of, right? People jumped in to go ahead and angioplasty jugular veins with no proof whatsoever in a controlled study. When we finally did the two placebo-controlled sham control studies, they were negative, And so I think that's a situation where you have a, standard of care that's less invasive, and you're offering a risky therapy. And the reason it came to light was that there were some terrible adverse events that occurred, on patients. And so I think the key thing is put the patient first. Would you subject your family member to a procedure like this if you knew there was no proof, And sometimes the answer would be, well, I don't want her to have surgery, and maybe that's yes, but other times it's going to be no. And I think we have to use that barometer. We did get into it. Sometimes it's a tricky situation for us. The problem we had was that people were really wheeling themselves in the wheelchairs into our office. And we felt terrible because we're trying to talk them out of wanting this, right? But that's because people went online irresponsibly and promoted this as something that could help them, right? So we just have to be very careful in how we approach, how we talk about these things as well. We shouldn't be promoting it actively until we really do have the evidence. I can't see the audience totally. Were there other, yeah, go ahead. Other questions or comments?
I don't see any
Yeah, I think,
in the
oh, go ahead.
chat or anyone's raising their hand. So we'll end with one final question. Clinical trials really shape the direction of our field. So what do you think is the future of VIR? And two, what advice would you give to VIR trainees interested in clinical research or leading big trials like what you have done with the tract?
Yeah, I think it depends on how confident you are that that's a direction you want to go. For those that feel pretty sure that's the kind of thing they want to do, if you're able to build in time in your residency to do some type of research training program, and I would say try and get a master's, in master's in clinical investigation or epidemiology or public health or one of these kinds of clinical, research kind of degrees, because I felt jealous because I never had that kind of training. There have been times when I think I would have designed my research a little bit better if I had it. It also gives you a bit more credibility, and when it comes to going out and getting grants and things like that, you're really in a little bit better position to succeed. Now, again, taking a year to do that kind of thing it's not, there's a big opportunity cost, that involves. Obviously, every year you don't spend practicing, it's a pretty. You don't do it when you're early on, you're not likely to ever do it later, obviously. So it is a good thing to do if you're thinking about that. But either way, I think that again, the scholarship in your area of interest, reading not just the IR literature but other literature as well is just so important, because you have to learn to talk other people's language, right? Because to really get there, to list them as allies, if we're just talking from our perspective, it's going to be very hard to really get people to sign on. I think those things are very important for us, and then just trying to follow the patient populations. I think that we have a great opportunity. I mean, we have we're the quality of the trainees in our field is outstanding. It's really outstanding, and I think a lot of them are motivated to do these things. And so honestly, the challenge, it's at your end kind of, but it's also at our end to try and figure out what are the supportive mechanisms. Secretary for the foundation, the SIR Foundation, and a big reason I went back into it and I'm putting more time into it is because I really hope we can find ways to better support young researchers, going forward, because I think there are some things that we can do to create kind of ways for them to get mentorship earlier and faster. Of course, grants, of course, but I think also just getting guidance on how to proceed. And I think the good thing is in IR, it's a friendly community, basically. I think that if you reach out to almost anybody, no matter how senior they are, they don't always have a lot of time to give you, but they will give you some time to help guide your career. And so, I encourage you all to do that.